This program is brought to you by Emory University.
Good morning, everyone. Hope everyone's okay. Leo Kniznik here, one of the chief fellows. Dr. Williams is on vacation, so he asked me to introduce Sophie today. So today we have Dr. Sophie Vitter presenting on semaglutide from weight loss, fad to protection in CAD. Sophie went to medical school in Louisiana State University in New Orleans and went to residency here at Emory University, and she's now one of our first-year clinical fellows. Take it away, Sophie. Thank you.
All right. Thank you, Leo. I appreciate that. Hi, everybody. I hope everybody can hear me okay. Today, I'm going to be presenting my fellows conference on, as Leo said, semaglutide from weight loss fad to protection in CAD. I know it's CAD, not CAD, but I really wanted it to rhyme, so I took some liberties. So there you go. So I have a few learning objectives. The first one is to review the effect of obesity on overall cardiovascular health. Next, to review the mechanism of GLP-1 medications and their effect on multiple body systems. Thirdly, to discuss some novel landmark trials investigating the effects of GLP-1 medications. And the main two that I'm going to focus on are the SELECT trial and the STEP-HFpEF trials. And then finally, to consider how we might utilize these medications in our own practice in the future. So I'm going to start with a clinical, sorry, let me try to get it to move on. Okay, there we go. I have no conflicts. And then I'm going to start with a clinical scenario. So this is just an example patient, 56-year-old gentleman with a history of hypertension, CAD, with a PCI in the past, hyperlipidemia, comes to your cardiology clinic at Grady or the VA just for routine follow-up. He's actually doing pretty well. He has no cardiac symptoms. His only complaint is trouble losing weight despite diet and exercise interventions. At home, he takes atorvastatin, clopidogrel, metoprolol, losartan. His vitals actually look very good. His blood pressure is pretty good. Only thing is that his BMI is 29. And his A1C last month was 5.1%. So he does not have diabetes. And he says to you that he's seen ads on TV for that new weight loss drug that all the celebrities are taking. And he wants to know if he's a candidate for it. So what do you say? What do a lot of us say? And I'll be honest, what I say in the past is talk to your PCP about it, because that's kind of an easy thing to have someone with a little more expertise on this talk to them about it. We don't really know as much about this drug. We don't prescribe it routinely. It's not something that we are really used to giving out in our cardiology clinics. So we say, maybe it would work, maybe it wouldn't, but you should talk to your primary care doctor about it and send them on their way. And so I'm going to kind of talk about how we can be more comfortable prescribing these medicines for our patients. So first, just a little bit about obesity. And a lot of this is things that we all already know, but I just want to go over it because it really shows how widespread this issue is. So over 50% of the world population, and that's the world, not just the US, is projected to be classified as overweight or obese by the year 2035. And obesity prevalence is affected by a lot of things beyond just our weight and our health status, such as race, socioeconomic status, education, and geography as well. And some of the most affected groups are non-Hispanic Black adults, lower socioeconomic status, and that's actually more so recognized in women rather than men, adults without a high school diploma, and then people in the South. And interestingly, there's a strong correlation between level of education. As it increases, obesity decreases. And so as you can see by these groups, this is a lot of the groups that we treat each and every day. So it's something that we really need to know a lot about. So this is just a nice map of the prevalence of obesity based on self-reported weight and height among US adults in 2022. And you can see, Georgia's right there in that little southeast corner that has some of the highest prevalences. Georgia actually is 37% as of 2022. And then if you look in non-Hispanic Black adults, it's even worse. And it's kind of in that same southeast area where Georgia is, where we see a lot of the prevalence. And then this map is is different, but kind of the same if you look at it. If you look at where the darkest color is, again, in that southeast area where we're located. And this, although is not obesity, this is heart disease death rates. And so it kind of proves what I think we all know from common sense and from practice, that these things are related to each other, and that obesity has a huge effect on cardiovascular health. So now I'm just going to talk a little bit more about that effect. So the association between obesity and cardiovascular disease. Overweight and obesity are independently associated with increased risk of cardiovascular events, even after the influence of metabolic cardiovascular risk factors has been accounted for. And interestingly, if you look to the right at this little graph, previous studies have estimated that about 45% of the increased risk of cardiovascular disease associated with a BMI over 25 or being overweight can be attributed to blood pressure, cholesterol, and or glucose levels. So those are all the things that we classically think of in people with an increased BMI that are contributing to their bad cardiovascular health. But we're seeing that we can chalk that up to about 45% of it, meaning that over 50% is not related to these factors. So there's something else going on as well. So although reducing the risk of cardiovascular disease by treating dyslipidemia, hypertension, diabetes is all standard evidence-based practice that we're all very comfortable with, the practice of treating obesity in and of itself to reduce cardiovascular risk has kind of been hampered by a lack of evidence in the past. And so this is just a little bit of a few studies I wanted to point out about obesity and cardiovascular disease. So the first one is actually looking at a follow-up of participants in the Framingham Heart Study from 1983. And it did show that obesity was a significant independent predictor of cardiovascular disease, particularly among women. Now, the second study is a pretty big meta-analysis of over 300,000 patients looking at the association of overweight with increased risk of coronary heart disease. And here, this is kind of where I got the previous numbers I was talking about, showed that adverse effects of overweight or blood pressure and on blood pressure and cholesterol levels could account for about 45% of the increased risk of cardiac disease. And this last one showed similar results. And this looked at 1.8 million participants. It was a pooled analysis of 97 prospective cohorts. And it similarly showed that 46% of the excess risk of BMI for coronary heart disease is mediated through blood pressure, cholesterol, and glucose. Again, meaning that over half is not mediated by those things. So now to talk about the actual medicines that I'm going to discuss today, and those are the GLP-1 receptor agonists, specifically semaglutide, which is Ozempic when used for diabetes, or Wegovy when it's used for weight loss. And just a little bit about GLP-1 receptor agonists as a whole. The first one that was FDA approved in 2005 was exenatide. And then in 2012, Novo Nordisk started developing semaglutide as a once-weekly diabetes medicine. And it went through trials in 2016, 2017, was released on the market, and then since then has really rose in popularity. And now we're really all hearing a lot more about it. So a little bit about the mechanism of GLP-1. GLP-1, or glucagon-like peptide 1, is a gut hormone that's released in response to food intake, and it acts as a satiety signal. It's released from the distal ileum within minutes of a meal, and it stimulates insulin release. It inhibits glucagon secretion. It increases glucose uptake and glycogen synthesis in peripheral tissues, and it delays gastric emptying. And here are just a few more really broad effects that GLP-1 has throughout the entire body, not just in the brain, not just in the gut, but in the heart, which we're obviously going to talk about, and in a bunch of other organ systems. It decreases inflammation, decreases postprandial lipids, decreases coagulation, increases natriuresis, diuresis, decreases blood pressure.
Well, apparently it's semaglutide.
Oh, okay.
I've been saying semaglutide.
Oh, I don't know which one is right for whoever's saying that. I say both, so. And decreases body weight. And it probably does even more than these things that we haven't even realized yet. So I'd be remiss if I didn't at least mention some adverse effects, since this is a new drug, and a lot of us are probably hesitant to be prescribing it because we don't know as much about, what are the adverse reactions that people might have. So most frequently, those are nausea, vomiting, diarrhea. However, these are often self-limited to initiation of the drug or dosage increases, and often they go away for our patients. Sometimes people will have dizziness, some mild tachycardia, headaches, dyspepsia. Of course, since a lot of these are subcutaneous injections, injection site reactions are always a risk, but they're no more increased than any other subcutaneous injection. And then finally, one that I think a lot of us have kind of heard about that gives us pause is acute pancreatitis. And it has been noted in some patients taking these medications. However, there's not really good evidence that a causal relationship exists. And actually, recent evidence, including the SUSTAIN-6 trial, has shown no increased risk of acute pancreatitis with semaglutide. So, I don't know that this actually portends the increased risk that we might think it does. However, anyone who gets pancreatitis while taking this medicine or has a history of acute pancreatitis should not take this medicine. Okay, I know this is a lot of previous literature, so I'm not going to belabor the point, but these are just a few studies on GLP-1 medications that I just wanted to quickly highlight before we get into the main ones that I'm going to talk about. So essentially, the SCALE 2015 trial, the SUSTAIN trial, and the STEP 1 study trial, they were all kind of similar studies that showed that GLP-1 receptor agonists result in greater weight loss than placebo in patients with and without diabetes. And then of note, the STEP 1 study actually showed improvement in cardiometabolic risk factors in addition to weight loss. So then when we get into the bottom two studies, which started to look at the actual cardiovascular benefits, the first one being liraglutide and cardiovascular outcomes in 2016, which looked at patients with diabetes and high cardiovascular risk and did show that the rate of first occurrence of death from cardiovascular causes, non-fatal MI, or non-fatal stroke was significantly lower with liraglutide than with placebo. And then finally, most importantly, the SUSTAIN-6 trial, or semaglutide and cardiovascular outcomes in patients with type 2 diabetes, which was published in 2016, showed that in patients with diabetes who are at high cardiovascular risk, the rate of cardiovascular death, non-fatal MI, or non-fatal stroke was significantly lower among patients receiving semaglutide than those receiving placebo. And so this SUSTAIN-6 trial was the one that really got us into the next trial that I'm going to talk in a lot of detail about, the SELECT trial. So we figured out that there's cardioprotection with these medicines in patients who have diabetes. So the appropriate next question is, what about patients who don't have diabetes? Can they benefit from these medications? So the SELECT trial aimed to answer the question, can semaglutide reduce cardiovascular risk associated with overweight and obesity in patients without diabetes? So it was a pretty big multi-center, double-blind, randomized placebo-control trial conducted at over 800 clinical sites in over 40 countries, having over 17,000 patients. The patient population was 45 years or older, a BMI of greater than or equal to 27, and having established cardiovascular disease. And that was defined in this study as a previous MI, a previous stroke, or symptomatic PAD. And so this is just a little bit more about the trial. You can see that patients were randomly assigned in a 1-to-1 ratio without stratification to receive once weekly subcutaneous semaglutide 2.4 milligrams versus placebo. The primary endpoint was a composite endpoint of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. And then there were also a few confirmatory secondary endpoints, and those were death from cardiovascular causes, a composite of heart failure endpoint, and death from any cause. And then just in the bottom right, you can see a few key exclusion criteria, which are, of course, a previous diagnosis of diabetes and an A1C level greater than or equal to 6.5, because as I said, the whole point of this is to look at patients who don't have diabetes, and then treatment with any glucose-lowering medication or GLP-1 medication in the past 90 days, no IHA class 4, heart failure, or ESRD. So we don't have to look at this entire table, but just a few of the baseline characteristics that I wanted to point out. The mean age was about 61 to 62. You can see that it was certainly male predominant. And then also, unfortunately, there was not a lot of ethnic diversity. We can see that the white population was like 83, 84% in both groups. The average BMI was 33 in both groups. And then you can also see that more than 3/4 of the patients that had a previous MI, and nearly 1/4 had had chronic heart failure. So these are true cardiovascular patients that are included in this study. And so now the most important, the results. And so here are the graphs, but just to kind of go over these results, essentially patients in the semaglutide study arm experienced a significantly lower rate of the primary outcome, which again was that cardiovascular composite endpoint. And it was 6.5 versus 8%. The hazard ratio on that is 0.8. Now, unfortunately, there was no significant difference in rates of cardiac death, as you can see in the top right. However, there were significantly lower rates of heart failure and all-cause mortality, as you can see on the bottom. And just a few conclusions about this SELECT trial. Overall, among these over 17,000 patients with BMI greater than or equal to 27 plus cardiovascular disease, but without diabetes, treatment with semaglutide at a dose of 2.4 for a mean duration of 33 months reduced the risk of a composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke by 20%. And again, that hazard ratio is 0.8. And then additionally, the incidence of serious adverse events was actually lower in the patients assigned semaglutide than those who received placebo. So this trial overall is a huge success, showing that there is cardioprotection in these patients, even if they do not have diabetes. Now, a few limitations and considerations to talk about. The BMI cutoff is a little weird, like 27. That's kind of between overweight and obese, but that's the one they chose here. Which I pointed out in the previous characterizations of the patients. There's a male predominance, there was a white predominance, so this isn't necessarily applicable to all patient populations. So that's something else to consider. So we now have talked about the fact that we do know that these medicines are cardioprotective, but I want to talk about why they might be cardioprotective and what kind of proposed mechanisms there are. So I'm going to first talk about the most obvious one, which I think we all can understand and we all kind of know, is that GLP-1 acts as a satiety signal in the brain. So it causes decreased appetite as well as slows gastric emptying. So all of these things lead to decreased caloric intake, which leads to weight loss, and then all of the cardiovascular benefits that come from weight loss that we discussed earlier in this talk. So that's super obvious. This is a medicine that's finally successfully helping people lose weight. And so, of course, with decreased BMI, with reduction in obesity and overweight in these patients, they have those cardiovascular benefits that come from that. This is obvious. This is well-established mechanism. However, weight loss alone is likely not the only explanation for the cardioprotective effects of this class of medicine. And the reason I say that is that because although semaglutide improved cardiovascular outcomes in this trial, lifestyle and pharmacological interventions for overweight or obesity in previous trials have uniformly failed to do so, even when weight loss was achieved. So one study that I'm just going to briefly point out is this 2013 study, Cardiovascular Effects of Intensive Lifestyle Intervention in Type 2 Diabetes. And this study examined whether an intensive lifestyle intervention for weight loss would decrease cardiovascular morbidity and mortality among patients. So unfortunately, this trial was stopped early on the basis of futility analysis when the median follow-up was about 9 to 10 years. Weight loss was greater in the intervention group, so that group that was doing the intense lifestyle changes, than in the control group throughout the study. So the biggest benefit was at 1 year. There was an 8.6% decrease in body weight in the intervention group versus 0.7% at 1 year. And then as the study went on, there's gradual regain of weight, and those numbers got closer to each other. But in that first year, it was 8.6% in the intervention group versus 0.7% in the control group. And so I just want you to take note that the amount of weight loss at 1 year was not that much less than that among the semaglutide in the SELECT trial, which was 9.4% versus this 8.6%. So you can see in this trial, some weight loss was achieved. However, the primary outcome, a composite of death from cardiovascular causes, non-fatal MI, non-fatal stroke, or hospitalization from angina, which again is a similar outcome to that in the SELECT trial, there was no benefit in the group with the intensive lifestyle intervention. So now I'm going to talk about, if it's not purely the weight loss, what other mechanisms of GLP-1 effect could be causing this cardioprotective effect. So one that I think is probably huge is targeting the inflammatory response. There's robust evidence showing that GLP-1 increases in the body in response to inflammation and stress, and in turn, it enacts mechanisms to reduce inflammation. And we've seen that IL-6 directly increases secretion of GLP-1 from the enteroendocrine L cells. And then GLP-1 goes down and exerts acute anti-inflammatory, antioxidant actions in humans under specific controlled conditions. And these effects are not simply mediated by changes in insulin levels. So I'm just going to talk about a couple of studies that have proven this. There's one 2014 study of critically ill patients. And in these patients, levels of plasma GLP-1 were markedly elevated, more than 7-fold in these critically ill patients. And then similarly, there was a 2-fold increase in GLP-1 in patients who were non-diabetic human patients who had cardiac surgery within 24 hours, showing that inflammation and that stress increased the levels of GLP-1. And then a separate study, which was also in 2014, employed euglycemic hyperinsulinemic clamps in non-obese human subjects with diabetes. And in these patients, co-infusion of GLP-1 decreased circulating levels of IL-6, ICAM, and other inflammatory markers under conditions of normal or increased insulin in the presence of euglycemia. So here we can see that GLP-1 exerts acute anti-inflammatory and antioxidant actions in humans under specific controlled conditions. And so just a little bit more about this, both native GLP-1 and GLP-1 receptor agonists reduce cardiac and vascular inflammation. And some ways that they do that is that they reduce vascular monocyte adhesion and macrophage accumulation within the blood vessels of several strains of mice at high risk for development of atherosclerosis and cardiac dysfunction. And actually one super interesting study that I'm just going to touch on was on exenatide, and it actually was shown to provide benefit in STEMI patients after getting it for just 3 days. So this was a randomized placebo-controlled study where they administered daily exenatide for 3 days in patients with a STEMI who were treated with balloon angioplasty and stents. So the patients either got 3 days of exenatide or control. And the exenatide therapy actually reduced levels of creatinine kinase MB and troponin, and also decreased infarct size as assessed by cardiac MRI about 40 days after reperfusion. And then furthermore, on echo analysis at 6 months after reperfusion, revealed persistent improvement in diastolic function and global longitudinal strain after the exenatide administration. So this is just 3 days of one of these GLP-1 medications in the setting of an acute STEMI, and it showed these long-term benefits on their recovery. And then there's been a bunch of other studies in rat and mice models that just have further evidence about the cardioprotection and the anti-inflammatory mechanisms of GLP-1 medications. So now I'm going to talk about the second biggest trial that I want to talk about these GLP-1 medications, and that's the STEP-HFpEF trial. It's very new, and this trial investigated whether once-weekly semaglutide at a dose of 2.4 milligrams might lead to reduction in symptoms and physical limitations and to improved exercise function in addition to weight loss in patients with HFpEF and obesity. So this is a randomized, double-blind, placebo-controlled trial at 96 sites in 13 countries, and it had about 529 participants total. And so this is just a little bit about the patients that were included in this STEP-HFpEF trial. Over 18 years old, LVEF greater than or equal to 45%, because again, this is HFpEF, not HFrEF. BMI greater than or equal to 30, NYHA class 2 to 4 symptoms, KCCQ CSS score of less than 90 points, 6-minute walk distance of greater than or equal to 100, and then greater than or equal to one of the following: elevated LV filling pressures, elevated pro-BNP plus echo abnormalities, or a heart failure hospitalization in the past 12 months, plus ongoing treatment with diuretics or echo abnormalities. So I do want to point out these kind of elevated LV filling pressures, heart failure hospitalization, this inclusion criteria. Because the reason that they did this in the study is that we know that in obese patients, BNP levels are lower than they otherwise would be. So it's kind of hard to say, give a BNP cutoff, because even if these patients truly have HFpEF, their BNP levels might not correlate with their disease. So that's why the people in the study tried to kind of show different mechanisms of true HFpEF by showing there were elevated LV filling pressures, or that you had this elevated pro-BNP plus echo abnormalities, or that you had a hospitalization or proven yourself to have clinical issues from your heart failure and needing diuretics or having echo abnormalities. So they're trying to just not show that just the BNP, because we know that's not as reliable. And then exclusion criteria were prior or planned bariatric surgery, patients who had already had significant weight loss in the recent past, a recent adverse cardiovascular event or heart failure hospitalization, and of course, an A1C level greater than or equal to 6.5%, or a known history of diabetes. Because again, this study, like the previous SELECT study, is trying to look at patients who do not have diabetes and see if these medicines portend some kind of benefit for them. And so this is just a brief review. Many of you may know this, but I just wanted to go over the Kansas City cardiomyopathy questionnaire because it's a big part of this study. And I think it's something that we don't use like as much as we use the NYHA classifications. So it's just a 23-item self-administered questionnaire that was developed to measure patients' perception of their health status, their symptoms, the impact of physical and social function, and how their heart failure impacts their quality of life. And this is all in a 2-week recall period. Now, specifically, the clinical summary score, or the CSS, provides a measure of symptoms and physical limitations associated with heart failure. And so this is scored from 0 to 100. To make it simple, 0 is the worst, 100 is the best. And so you can see, looking at this chart, that really low scores in the 20s, 30s are correlated with like NYHA 4, whereas scores in the 80s or 90s are more consistent with NYHA 1. And then everything in between is kind of filled out. So that can just give you an idea of what these scores really mean. And so in the study, they wanted people with a KCCQ CSS score of at least less than 90, just to show that these patients have true clinical heart failure that's causing issues in their everyday life, and that is affecting them and causing symptoms, so that when we do the study, we can see if there's any improvement. And so again, just a little bit about the patients who participated. The mean age was 69. This one, even more so than the SELECT trial, there was a really white predominance with 95%, which is a little bit surprising to see. And then the median BMI was 37. And then finally, of note, most were NYHA class 2 at 66%, but there were also a pretty good percentage of class 3 or 4. So these patients have symptomatic heart failure. So here are the results that we're going to kind of go over. And again, the main things that we looked at were the change in KCCQ CSS score and the change in body weight. And you can see from looking at these graphs that there was a statistically significant difference. The mean change in KCCQ CSS at week 52 was 16.6 points in the semaglutide group and 8.7 in the placebo group. And so that's a pretty significant difference. And then the mean percentage change in body weight at week 52 was 13.3% for semaglutide and 2.6% for placebo. So again, there was good success in this trial showing that, of course, change in body weight was better for the semaglutide group, unsurprisingly, and change in symptoms as assessed by the KCCQ CSS score was also significantly improved in the semaglutide group. And then these are just a few of the other secondary outcomes that they wanted to talk about. The change in 6-minute walk distance from baseline to week 52 was 21.5 meters versus 1.2 meters in the semaglutide group versus the control. And then interestingly, the change in CRP level, and I think this kind of goes back to what I had talked about inflammation being a huge mechanism of how these medicines kind of affect us by reducing inflammation. And so there was a 43.5% reduction of CRP level with the semaglutide group versus just 7.3 reduction with the placebo at 52 weeks. So I thought that was a really interesting outcome. Although it's not clinical, it's interesting to kind of speak to those mechanisms that we've spoken to. And then finally, the last thing they did was the stratified win ratio for hierarchical composite endpoint. And so this was a little bit confusing. I'm not going to go into super explicit detail, but they used the stratified win ratio to further analyze the results. And the basic concept of this win ratio is to define this hierarchy of clinical importance. And so you can see at the top is death, and then number of heart failure events, and then first heart failure event, and then this 15-point difference, 10-point difference, 5-point difference in the KCCQ-CSS. So it kind of goes down the line in order of importance. And then you kind of compare every subject in the treatment group with every subject in the control group, and then evaluate each pair and find if it is a win or a lose for the pair until all the outcomes are kind of exhausted. So it's a little bit confusing, but overall, it did show that semaglutide favored over placebo on all components of the hierarchical composite endpoint, with a difference of at least 15 points in the change in KCCQ-CSS contributing the most to the benefit. So the overall win ratio was 1.72, which is significant. So a little bit more about it. The serious adverse events were reported in 35 participants in the semaglutide group and 71 in the placebo group. So less adverse events in the actual intervention group. The number of participants who discontinued treatment because of adverse events was a little bit more in the semaglutide group than in the placebo group, but most of these were related to GI issues. And as I said, a lot of these nausea, vomiting, diarrhea, these GI issues that people experience often will go away with continuation of the medicine. It's often at initiation that people have these issues. And then just of note, during the trial, 7 participants died, 3 in the semaglutide group and 4 in the placebo group. Which kind of sounds like a lot, but just the 1 death in the placebo group was from a cardiovascular cause, and the other 6 deaths were from non-cardiovascular related causes. So I don't know really exactly how much impact those had on the study, but it's just something to note. So conclusions about this trial. To put it simply, once-weekly semaglutide at a dose of 2.4, again, led to larger reductions in heart failure-related symptoms and physical limitations, as measured by this KCCQ-CSS score, as well as a greater degree of weight loss than placebo at 52 weeks. Additionally, semaglutide increased the 6-minute walk distance, resulted in more wins in this evaluation of the hierarchical composite endpoint, and reduced CRP levels to a greater extent. And it also led to fewer serious adverse events than placebo and had a similar frequency of discontinuation. So, we talked a little bit about the proposed mechanisms of the benefit, but now that we've seen how it kind of affects these HFpEF patients, I wanted to talk about proposed mechanisms of GLP-1, of obesity, and HFpEF. So the first thing to kind of talk about is that, I think this is something we all know and we all experience, but there's kind of this suspicion that patients who present with signs and symptoms of heart failure with preserved ejection fraction, or HFpEF, who are also obese, might not really have heart failure, but instead are just obese and deconditioned and misdiagnosed. And I think it's almost fair to sometimes think that, because a lot of the symptoms of heart failure are similar to those of obesity: a decreased exercise tolerance, increased shortness of breath, things like that. It might be kind of hard to tell what's what. Increased BMI has even been a common exclusion criteria in past large clinical HFpEF trials. However, I think now it's kind of increasingly difficult to ignore this obese HFpEF phenotype that we're seeing, because in the United States, over 80% of patients with HFpEF are overweight or obese, and that's over twice the general population. So there's clearly something going on, even before the recent obesity epidemic, that shows that the population attributable risk for heart failure because of obesity is nearly as great as hypertension. So there's definitely something there. And so now let's talk about why adipose tissue increased obesity can kind of contribute to this HFpEF phenotype. So excess adipose tissue can produce impairments relevant to HFpEF by two general mechanisms. And so the first is like local or mechanical, and the other is more systemic and metabolic. So without going into too much detail, a few examples of kind of the local or mechanical mechanisms include enhanced pericardial restraint, decreased oxygen diffusion from capillaries to working skeletal muscle cells, accelerated coronary atherosclerosis associated with epicardial adipose, and then also accelerated renal dysfunction associated with pararenal fat. So all those things are happening locally at the organ. And then there are examples of more like systemic or metabolic effects. And we know a lot of these that are associated with adipose tissue, but adipose tissue is very metabolically active. It produces powerful vasoconstrictors, including angiotensin II. It also produces inflammatory cytokines. So all of those things contribute to HFpEF. Additionally, excess adipose tissue is associated with impaired mitochondrial function, which is present in patients with HFpEF and is actually thought to contribute to their severe exercise intolerance. And these are just a few of those potential systemic mechanisms whereby excess adipose contributes to HFpEF. And so this is just another chart that I think is a really great illustration of the potential mechanisms of benefit of semaglutide in individuals with the obesity phenotype of HFpEF. And so as you can see, they differentiate between the mechanisms that are directly related to weight loss, which are in blue, and those that are not, or are these additional mechanisms, and those are in green. And just a few of the ones that are directly related to weight loss are things like decreased plasma volume and stressed blood volume, decreased visceral, pericardial, intramuscular fat, decreased demand for high cardiac output, things like that. And then the more broad, more systemic things that we can't necessarily attribute to just the weight loss are things like decrease in inflammation, improved insulin sensitivity, improved microvascular function, vascular protection, a lot of the mechanisms that we talked about after the SELECT trial. So it's kind of interesting to see how kind of both of these contribute to this benefit in this HFpEF phenotype. Okay, so that is it for me. I'm just going to go over very broad conclusions for this talk. Semaglutide has shown a myriad of cardiovascular benefits beyond those that can be explained by weight loss alone. But of course, the significant weight loss benefit is something that adds further benefit to the cardiovascular protection. I think further trials are needed to ascertain whether semaglutide exerts a cardioprotective and preventative benefit in patients who don't have pre-existing cardiovascular disease. I think that's something really interesting. We know that it worked in patients with diabetes. Then we moved on to see, hey, in patients who don't have diabetes, can we still get these benefits? So now I think let's see in everyday patients who don't have any cardiovascular risk factors, can they still get benefit? Could this be some kind of primary prevention? And in conclusion, I think that we as cardiologists should consider incorporating semaglutide into our practice, just as we did other medicines that weren't necessarily made for us or made for the heart, such as SGLT2 inhibitors, aldosterone antagonists, et cetera. These are all things that kind of were made for other purposes, but now are so integral to our practice. And I think that GLP-1 agonists could be the next medicine that we use, even because it wasn't made for us, but I think it could provide a lot of benefit for our patients. Thank you all for listening. And special thank you to Dr. Tamala for her mentorship and review. And then I just have a few references and that's it. So again, thank y'all. And I'd love to answer any questions anybody has.
Thank you so much, Sophie. I had one question. Do you know if there are data on the incidence of atrial fibrillation, if it decreases, stays the same, or increases with these medications? I know there's like one small trial that was presented at HRS a couple of years ago, but that was for people that already had AF and it decreased the burden a little bit, you know? Thanks.
Yeah, no, I think that's a really interesting question. And I did not see really a lot of data on that. But I hope and kind of expect that there might be more coming out about that now that we've kind of established the cardiovascular benefit as a whole, because I think that could be really interesting. But I agree, I didn't see a whole lot on that.
Okay, thanks.
This is Dr. Sherman, Sophie. Very good talk. Has there been any ideas or any thoughts about SGLT2 versus SGLT1, and were these people in these studies on both at any point? And I guess, also the payers, how do they feel about these drugs?
Yeah. That's a good question, because, a lot of these patients are on SGLT2 as well. I haven't seen anything specifically comparing them. I know there's no, contraindication to having both. So I think a lot of the patients in the studies were on SGLT2. I'm not sure if I have anything specifically in the studies that kind of shows the patient populations, that shows what other medicines that they were on. But I know that some of them were on SGLT2. So, there's no necessarily contraindication. As far as the payers and their thoughts on that, I mean, I think that's a really interesting question, and I don't know the answer to that. I know that they are looking at some new GLP-1 medicines like tirzepatide and retatrutide that are looking at combinations. Like tirzepatide is GLP-1 plus a GIP agonist, whereas retatrutide is in phase 3 trials. That's GLP-1 plus GIP plus a glucagon agonist. So could they kind of look into something that's a GLP-1 plus an SGLT2, maybe. But I don't necessarily know the answer to that, but I think it's something to consider.
Yeah, Sophie, this is Andy Smith. That was a great talk. Barry Borlaug at Mayo has studied this heart failure phenotype, this obesity phenotype in HFpEF, and has an interesting study where they did right heart catheterization on patients with obesity. And the hallmark of that is that when you exercise these patients, that their wedge pressure goes up very quickly. They can even start with a relatively normal wedge pressure, but with exercise in the lab, it shoots up even more so than what you would see with volume loading. So again, you pointed out that patients who are short of breath with obesity, it's not necessarily just because they're obese. And there's a HFpEF score that if you have a BMI over 35, your likelihood of having HFpEF goes way up. And I really like your comments tied into inflammation and obesity. Obese patients, more likely to have psoriasis, a whole number of diseases. And one question for you. So the mechanism of this was actually people ate less, right? I was
Correct.
at dinner, yeah. I was at dinner with a friend last night who's lost 35 pounds, and he said, "Man, that drug just it knocks out your appetite and that sort of thing." So I think, would it be true to say that patients who say that they don't eat anything, but they can't lose weight, is it true that by just reducing their calorie intake that they will lose weight? Another comment along those lines is we had a lot of patients years ago when we did the HF Action study, which was a cardiac rehab study in heart failure patients who wanted to be in the trial to lose weight. And the patients who went through the cardiac rehab really did not lose much weight. Exercise tends not to be a great way to lose weight. And then just another comment that my friend said last night. He said, "Wow," he said, "when I went to get that medicine, it was a wallet biopsy." They said, "You owe $300 for this medicine." He said, "Well, I have medical insurance. Isn't it covering it?" And they said, "Yes, your insurance covered $1,100 of it." So the medicines are extremely expensive right now. And at least he was on Manjaro, but anyway, just some comments around that.
Yeah, no, thank you, Dr. Smith. I appreciate that. I think those are some really interesting comments, and to kind of speak to that, you're exactly right. Yeah, the mechanism by which people lose weight on these medicines is basically decreased appetite, increased satiety, so eating less. So, sometimes you have these patients who say they don't eat much, but they're still not losing weight. Would it work for them for weight loss? You're right, probably not, because the whole mechanism is that you don't eat as much and it's decreased caloric intake. However, I guess kind of on the flip side of that, the cardioprotective benefits of it that I kind of talked about, yes, a lot of those are attributed to the weight loss, but some of them are not. So even if we had, cardiovascular patients in our clinic who, maybe are one of those patients who don't lose a lot of weight with these medicines, don't have as much success there, I think there's still evidence that they could benefit from more of, as you said, the inflammation approach, and could still have benefits in their cardiovascular outcomes from these medicines. So I think kind of looking at it more widely, it's primarily, been used as a diabetes drug, now as an obesity drug. I think it can be kind of, maybe we could see it as a primary cardiovascular drug as well, that some people would have the benefit of weight loss with, and some might not, but still could provide benefit regardless. And then as far as the cost, yeah, that's really unfortunate. All of these new drugs, it's always something with them. And I've heard that from patients and from friends and family as well, that these things can be expensive. So hopefully they can kind of go down in the future as we get more of them and the prices can be more reasonable. But you're exactly right. That isn't something that certainly is an issue, especially for a lot of our patients getting these medicines. The price is going to be a huge issue to overcome. Any other questions?
I see that Will Mamo wrote a question on the chat. He says, thanks for the excellent presentation. Do you know of any effects of GLP-1 agonists on the lipid panel, raise or lower LDL or none HDL?
Yeah, good question, Will. So it actually has been shown in mechanisms to lower LDL. That has not specifically been studied like in the sense in the way that these other mechanisms have in these big randomized control studies, but more so in like smaller mechanistic studies, it has been shown to lower LDL. So I think that's another thing that we could get more data on to really prove that benefit. All right. Anything else before we wrap up?
Maybe I had to get off for a moment, but did the studies discriminate between central obesity and diffuse obesity or visceral obesity in any of these studies?
Yeah, no, good question. They did not. They did not specifically differentiate between those. And I think that's a really interesting thing to consider in these patients, because some of the like mechanisms of how obesity relates to HFpEF is, directly related to this visceral obesity, this adipose tissue in the actual organs in the heart and things. So they did not specifically differentiate between that. And I know that, some certain populations, like certain Asian populations and stuff, who, even though they're lean, have increased like visceral adiposity. I think those are populations that it might be a little bit different or interesting to look at kind of how their HFpEF phenotype might not necessarily be related to like central obesity, but more so this visceral obesity that still causes some of these more direct mechanistic issues within the heart, within the kidneys and things like that. So no, you're right. They did not differentiate between those two, but I think it's a good point.
That'll be interesting.
Yeah, definitely.
All right. Thanks so much, Sophie. And
Yeah.
see everyone next Friday. Excellent talk. Thank you.
Thanks, everyone. Thanks, Leo. Appreciate it. Have a good Friday.
The preceding program is copyrighted by Emory University.